Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Willkommen auf dem Kanal für Anästhesie und Perioperative Medizin.
Gracias por acompañarnos hoy en el canal de Anestesia y Medicina Perioperatoria.
आज Anesthesia और Perioperative Medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद. Today we're going to do a really deep dive into the anesthesia and perioperative management for what is honestly one of the biggest game changers in modern vascular surgery, endovascular aortic repair, which we all know as EVAR and TEVAR. So here's our game plan. We've broken this down into 6 parts to really cover all the bases. First, we'll start with a quick primer on the procedure itself, just to make sure we're all on the same page. Then, we're going to walk through the entire perioperative journey, from the preoperative clinic into the OR and all the way through to postoperative care in the ICU. And then, we'll wrap up by tackling the really critical complications, the things that keep us up at night, focusing on how to prevent them and what to do when they happen. So, let's jump right in. Okay. First things first, let's lay the groundwork. Really understanding the underlying problem and just how elegant this endovascular solution is, well, that's absolutely key to appreciating our role as anesthesiologists in making sure these cases go smoothly and our patients have the best possible outcomes.
The whole reason we're here is the aortic aneurysm. It's the silent, creeping dilation of the biggest artery in the body. And the real danger, as we all know, is that the risk of rupture, which is almost always catastrophic, goes up exponentially as that aneurysm gets bigger. This is literally the ticking clock that brings these patients into our operating rooms.
And this slide just perfectly illustrates the genius of the endovascular fix. I mean, instead of a massive open incision, you can see in diagram A how a catheter is just threaded up through an artery in the groin. Then, the stent graft is deployed, and it pops open, creating this brand new protected channel for blood to flow through. And the result, which you see there in diagram B, is that the aneurysm sac is totally excluded from all that systemic pressure. The risk of rupture is basically neutralized. It's an incredibly clever and effective approach. Now, for us in anesthesia, this is the really crucial part, understanding the massive physiological differences between this and a traditional open repair. With an open case, you're talking about a huge laparotomy or thoracotomy, you've got a long aortic cross-clamp with all the ischemic chaos that unleashes, you're dealing with huge fluid shifts, and major blood loss. Endovascular repair, because it's so minimally invasive, lets us sidestep most of those huge physiological insults. And that's exactly why it's become the go-to procedure for so many of our patients, especially the older, sicker ones with a ton of comorbidities. And this technology didn't just pop up out of nowhere. The whole journey actually started back in 1987 in Ukraine with Dr. Volodas, but it was Dr. Parodi's procedure in Argentina in 1990 that really brought it onto the world stage. From there, you see these key FDA approvals. In 2005 for the thoracic grafts, or TEVAR, and then this was a huge one in 2012 for fenestrated grafts, FEVAR. Those fenestrated grafts were a game changer because they let us start treating really complex aneurysms that involved the renal and visceral arteries, stuff we couldn't touch with the earlier devices. All right, so let's get into our world now, the preoperative phase. This is really where the magic starts for us. Meticulous planning, patient optimization, this is where we lay the foundation for a successful case. Honestly, our work here is every bit as critical as what happens with the knife, or in this case, the catheter. Our pre-op assessment has to be a real deep dive. It goes way beyond just the standard review of systems. We absolutely have to know the patient's functional status. Can they walk up a flight of stairs without getting winded? Their day-to-day mobility is one of the most powerful predictors of how they'll handle the stress of this surgery. We also need to get our own eyes on that CT angiogram. We need to understand the aortic anatomy, sure, but we also have to look for critical collateral vessels, especially the artery of Adamkiewicz. And of course, using tools like the revised cardiac risk index helps us put a number on that risk and guides how aggressive we need to be with our optimization. This table really breaks down our targeted plan. A few key things to point out. Cardiovascular-wise, you have got to know if they've had a K-badge with a Lima graft. Why? Because that Lima comes off the left subclavian. And if that artery gets covered during a TEVAR, you've just knocked out a coronary bypass graft. That's a disaster. For the kidneys, the absolute cornerstone is hydration before they get that big bolus of contrast. And neurologically, getting a crystal clear baseline is everything. If you don't know where the patient started, you'll have no idea if a new postoperative deficit is actually new. Now this is probably one of the most high-stakes conversations we have with the surgical team before the case. Managing these antithrombotic meds is such a delicate tightrope walk. The main reason we want them stopped is because we might need to place a lumbar drain for CSF pressure monitoring to protect the spinal cord. And a spinal hematoma from that is a nightmare complication we can't risk.
But you have to individualize the plan. For a patient who just got a drug-eluting stent in their LAD a few months ago, stopping their Plavix is also a massive risk. For the urgent cases, yeah, we can reverse them. But notice that critical note. In that scenario, you typically do not place a CSF drain preoperatively. It's just too risky.
Okay, let's head into the operating room. Now our focus totally shifts. It's all about vigilant monitoring, super tight hemodynamic control, and just being ready for anything and everything that can go wrong. Let's walk through the intra-op protocol. Our monitoring setup needs to be rock solid, and every piece has a purpose. That preference for a right-sided A-line, it's not just a suggestion. During a TEVAR, the surgeon might cover or clamp the left subclavian artery. If your only A-line is in the left radial, it's going to flatline right when you need it the most. You have to have large bore central access, no question. We need the ability to give volume fast. A PACath isn't for every single case, but for your patient with an EF of 30%, it is invaluable. And here's a pro tip. Put the cerebral oximetry stickers on before you induce. You want that stable, awake baseline so you know what you're trying to get back to throughout the case.
So how do we decide on the anesthetic? GA versus MAC? Well, it really comes down to the complexity of the repair. For those really complex fenestrated or branched repairs, the FEVRs or BVRs, that are going to take hours and might need extra access sites like the axillary artery, general anesthesia is really the only way to go. You need absolute stillness and total control of the airway. But for a straightforward, percutaneous, below the kidneys EVAR, MAC, or even a spinal is a totally reasonable choice. There's some data suggesting it might even get patients home faster. But you absolutely have to be ready to convert to GA in a heartbeat if things go sideways. And that leads us right to this, the conversion protocol. This is our break glass in case of emergency plan, and everyone needs to know it cold. The second you recognize a problem, the patient's moving, their pressure's cratering, the surgeon says, uh-oh, the whole thing kicks into gear. Priority number one is securing that airway, usually with an RSI. At the same time, you're pushing pressors and fluids to stabilize the pressure. You've got to communicate clearly with the whole team, and you always have to be thinking 2 steps ahead. That means anticipating a full-on open conversion and being ready to call for the massive transfusion cooler. These are the numbers we live by during these cases. That MAP goal of 85 to 100, that's a lot higher than your average case, and for a very good reason. It's all about ramming blood flow to the spinal cord and the kidneys. Systemic heparin is a must to stop clots from forming on all the wires and catheters, so you'll be checking ACTs constantly. And don't underestimate the blood loss. It can be a slow, sneaky ooze from multiple big groin sheaths that adds up really fast. Our transfusion targets are also aggressive, all aimed at optimizing oxygen delivery and making sure the patient can form a clot when we need them to. If you remember one equation from today, make it this one: spinal cord perfusion pressure. It's the lifeblood of the spinal cord. The concept is actually really simple. Your MAP is the pressure pushing blood in, and your CSF pressure is the pressure pushing back. Our entire management strategy is built around maximizing this difference. We aggressively jock up the MAP with pressors, and if we have a drain, we open it up to lower the CSF pressure. Hitting that target of over 70 to 75 is one of our most important jobs in the whole case. So, the graft is in, the surgeon's happy, and the procedure is technically done. But for us, the work is nowhere near over. That immediate postoperative period is when patients are incredibly vulnerable. Let's look at what we need to focus on in this critical phase. Think of this table as your ICU playbook. We're basically just continuing our intraoperative goals. The big themes are still there. Keep that MAP high for the spinal cord, make sure the cardiac output is solid, protect those kidneys, and keep the patient warm to prevent shivering, which can cause a huge spike in myocardial oxygen demand. A really clear, goal-directed handover to the ICU team that spells out these exact targets is absolutely crucial for a safe transition of care. Okay, let's talk about the things that can go wrong. We work so hard to prevent these, but we absolutely have to be ready to jump on them the second they happen. We'll focus first on the big ones, neurologic and cardiovascular events. Spinal cord ischemia. This is, without a doubt, the complication we fear the most with big thoracic aortic repairs. It is just a devastating event, one that can leave a patient permanently unable to walk. And understanding how it happens is the first step towards stopping it. And these diagrams show you exactly why the spinal cord is living on the edge. The front 2/3 of the cord, where all the motor tracks are, is supplied by one single solitary anterior spinal artery. That artery gets its blood from a series of smaller segmental arteries, and the biggest and most important of them all is the artery of Adam-Kievich, the AKA. So when a surgeon covers a long start to the aorta with a stent graft, they can easily block off the origin of the AKA and other key intercostal arteries. That's what puts the cord at such a huge ischemic risk. It's a plumbing problem, plain and simple. So who are the patients we need to be extra worried about?
This table spells it out. Procedurally, it's pretty straightforward. The more aorta you cover, the higher the risk. Covering the left subclavian or the hypogastric arteries is also bad because you're taking out key collateral pathways. From the patient's side, if they've already had a previous aortic repair, that means some of their collateral network is already gone, making them more fragile. And then there's the one we control, hemodynamics. Any period of significant hypotension is a major, major hit against the spinal cord. Our vigilance here is everything. Now, what if it happens? The ICU nurse calls you, your post-op patient can't move their legs. The clock is ticking. This is our rescue algorithm. Step 1, and you do this immediately, is crank up the MAP. Get it to 90 or 100 with pressors and volume. Step 2, you attack the other side of the SCPP equation. Drain the CSF. If there's a drain, open it. If there isn't one, someone needs to put one in, stat. Then you optimize everything else. Get their hemoglobin up over 10, make sure their volume replete. The adjuncts like steroids and mannitol might help with cord swelling. This is a true code stroke for the spinal cord. And if you move fast, sometimes, just sometimes, you can reverse it.
Beyond the spinal cord, we also have to worry about the brain. The overall risk of stroke after TEVAR is about 4%. But just look at this data on the left subclavian artery. If you cover the LSA and don't revascularize it, you pretty much double the risk of stroke, up to 8%. Even if you do revascularize it, the risk is still higher than baseline. The takeaway here is clear. Anytime you're manipulating wires and devices in the aortic arch, you risk knocking loose a bunch of atheromatous junk that can fly straight to the brain.
Post-op AFib is another one to watch for. It's less common than after a big open case, but when it happens, it can be really dangerous. That sudden loss of the atrial kick can cause an abrupt drop in blood pressure. And as we said a dozen times, hypotension is the enemy of spinal cord perfusion. So prevention is key. Make sure their potassium and magnesium are topped off. If it does happen, we tend to reach for amiodarone to try and get them back in sinus rhythm, rather than just slowing them down with beta blockers that could make the hypotension worse. And if they're unstable at all, don't hesitate. Get the pads on and cardiovert them.
Okay, for our final section, let's wrap up by covering the other major complications. We'll look at what can happen to the kidneys, problems with the graft itself, and the body's big systemic response to the whole procedure. Acute kidney injury is incredibly common after these procedures, and it's a serious problem. As you can see from this chart, it's really a perfect storm for the kidneys. The single biggest predictor is if they're coming in with bad kidneys to begin with. Then we layer on a huge contrast load, the constant threat of hypotension, and the risk of showering little emboli down into the renal arteries. It's really a multi-hit injury. For decades, we've tried all sorts of things to protect the kidneys from contrast. Bicarb drips, mucomist, you name it. But this quote from the big PRESERVE trial really put that debate to rest. The conclusion was crystal clear. None of it works. So the most important takeaway for our practice is that the best strategies for protecting the kidneys are the simplest ones. Give plenty of IV fluids beforehand, and push the surgeons and interventionalists to use the absolute minimum amount of contrast necessary to get the job done. All right, let's talk about the most common long-term problem after an EVAR, and that's the endoleak. All this means is that there's still blood getting into the old aneurysm sac, flowing outside the stent graft. This picture gives a great little roadmap to the different types, which we're about to break down.
This table really gets into the weeds, but here's the most important takeaway. Not all endoleaks are created equal. You need to know the difference between the bad ones and the not-so-bad ones. Types I and III are the really bad ones. They are high-pressure leaks that are directly repressurizing the aneurysm sac, which means the rupture risk is back. They need to be fixed, and urgently. In contrast, a type 2 leak, which is the most common, is a low-pressure, slow, retrograde flow from a little lumbar artery. Most of the time, those are just watched unless the sac starts to grow. Understanding that difference is absolutely key.
Here's a kind of weird complication you'll definitely see if you do enough of these cases: post-implantation syndrome, or PIS. The patient is doing great on post-op day 1, and then on day 2, they spike a fever, their white count goes up, and their inflammatory markers are through the roof. It's thought to be this massive systemic inflammatory reaction to the graft material itself. The most important thing is to not mistake it for an infection. The treatment for PIS is just supportive care, Tylenol, fluids, and it almost always goes away on its own in a few days. So, to wrap everything up, what are the big principles for getting these patients safely through this? First, it has to be a team sport. Seamless collaboration between surgery, anesthesia, and the ICU is non-negotiable. Second, we have to be systematic in identifying our high-risk patients so we can target our interventions. Third, it's all about meticulous, protocol-driven management in the OR and ICU, especially for hemodynamics and spinal cord protection. Fourth, we have to be hyper-vigilant and ready to launch our rescue plans the second a complication arises. And finally, we have to help patients understand this isn't a one-and-done cure. They need lifelong CT scans to watch for long-term problems like endoleaks.
And that really brings us to our final thought. The technology for these stent grafts is just exploding. We now have custom-made branched and fenestrated devices that let surgeons treat aortic problems that would have required a massive, prohibitive open operation just a few years ago. So the challenge for us as perioperative physicians is to make sure that our anesthetic techniques, our monitoring, and our critical care protocols are all evolving right alongside that technology. We need to keep pushing the envelope of what's possible while at the same time making it safer and safer for our patients. Thank you so much for joining us for this deep dive into endovascular aortic repair.